Welcome to EPG Pathshala. We will be discussing today the course on social policy. The specific module under discussion is health policy in the context of India. My name is Sohini Sengupta. I am an assistant professor in the School of Social Work at the Tata Institute of Social Sciences in Mumbai. Health is, along with education, a key social policy concern due to a number of reasons. The social and economic situation of individuals and groups has a direct effect on their health status. Poorer people, therefore, may also suffer from various health deficits. However, these are the very people who also lack the purchasing power to obtain expensive healthcare services or new medicines or take advantage of scientific breakthrough products. In addition, poor people may lack expert knowledge needed to understand the suitability of certain medical treatment and interventions for their condition. All of these put together makes healthcare a particularly important component of social policy. The objectives of this module is to enable students to understand health policies and programs in India briefly, to also look at the key findings from recent health surveys like the National Family Health Survey 4, to understand ongoing reforms in the health sector and the concept of universal healthcare, to address and understand debates about healthcare financing, and to also look at health insurance briefly as an instrument of social policy. Healthcare and social policy. There is a strong view that health should be viewed as a human right and not to be determined by people's socioeconomic or environmental context. Some aspects of healthcare are actually viewed as public goods, and these components are not amenable to market-based approaches and therefore require state intervention. These include areas around healthcare such as immunization, sanitation, reproductive health, public health, and so on. Disadvantaged social groups would constitute a vulnerable mass of people with urgent healthcare needs, but less ability to know about, less access to healthcare infrastructure, less affordability to buy health insurance or to pay for health services. When we try to understand the health status of the population in our country, a couple of indicators comes to our mind, because it's around these parameters that societies are judged nowadays in terms of whether they're healthy or not. India ranks poorly, for example, for reproductive, maternal, newborn and child health care. Malnutrition is still prevalent in the country, as only 50.5% of infants of 6 to 8 month period receive solid and semi-solid and soft food, which essentially mean that children are not getting weaned into diverse diet, leading to malnutrition at an early age. Around 69.5% of children between the age group of 6 months to 3 years suffer from anemia, which directly is connected to poor health of mothers, as well as inadequate nutritional and health practices, as well as the poor societal the poverty or other socioeconomic conditions to which they belong. Only 65.3% of children of 12 to 23 months have received full immunization, which makes them highly vulnerable to infectious diseases of all kinds. India accounts for 15% of global mental, neurological and substance use disorders in the world. Our interventions around mental health and neurological and other disorders is also not of a great order. The biggest reason for the slow improvement in health parameters in the country, according to some commentators, is the high out-of-pocket expenditure by Indian households. In fact, next to food, healthcare is probably one of the largest areas of expenditure. People are paying a lot of money for healthcare, not necessarily leading to greater health outcomes for them. The health insurance debate is really important in today's context. Only 10% of India's household has at least one member of the family who is covered by medical insurance in 2004-05, which essentially meant that if members of the household fall sick or have any other types of healthcare need, they would have to pay out of their own savings or their earnings to obtain good health. A small section of the population, a very small section of the population in fact, such as the employees of public sector units or central government, are able to obtain comprehensive medical insurance that covers their outpatient and hospital care under central government health schemes. But a vast majority, close to 83% of the population of adult working age, do not work for central government and do not have access to comprehensive insurance as part of their employment benefits. Coverage is also provided by employee state insurance scheme to groups of people who work in factories that employ more than 10 people. A large majority of India's working population is employed in the informal sector and in agriculture. For this group of poor and vulnerable population, regular contribution to medical insurance would incur a cost that would be highly unaffordable for them and therefore unfeasible. So health insurance coverage is available for a very small portion of the population at the moment. The Ministry of Health and Family Welfare, in collaboration with other institutions, has conducted several rounds of health surveys in the country. The objective of conducting health surveys is to obtain health related information which enables the government to understand the way in which government programs are functioning, the general health of the population, how to target their financing and interventions in the future, and also to allocate scarce resources efficiently. The objective of National Family Health Survey 4, which has been the latest in the round of family health surveys, is to provide data on important indicators in population health, family welfare, malaria prevention, migration HIV, and non-communicable diseases. Members of 600,000 households from 28,000 sample units consisting of villages and urban areas in 640 districts were interviewed using 4 survey schedules to obtain information for the National Family Health Survey 4. The findings show improvement in antenatal care and institutional birth as compared to the previous round of survey, reflecting the effect of government cash transfer programs JSSY and JSSK for improving maternal and child health care. We will be looking at some of these government healthcare programs in our module on cash transfers. Utilization of antenatal care was related to socioeconomic characteristics, however, of mothers and higher among wealthier women. What does this finding say? This finding suggests that although the proportion of families who were utilizing antenatal care and the proportion of families who are giving institutional birth has increased in numbers, when one looks at the data deeply, you realize that this increase in numbers is related to higher numbers of women who belong to better off families and also who have completed a certain number of school education were availing of these schemes much better than the groups of women who had not. This essentially means that although our infant mortality, maternal mortality and morbidity rates are improving and maternal and child health parameters are also improving, this improvement may not be equitably distributed in our population. So health surveys not only indicate access to healthcare, it also shows the extent to which healthcare interventions have been able to overcome the societal inequalities that exist in our country context. As of now, women who had completed secondary school education and who did not belong to disadvantaged social groups like SC, ST and OBC have been utilizing some of these government schemes and healthcare facilities better than others. The institutional childbirth has improved for all, with higher proportion among wealthier households and educated mothers. Age of marriage for women increased in all states between the 2 rounds of survey, which essentially meant that women are marrying later and later, and the incidence of child marriage is reducing even in the states where it was highly prevalent in the past. At the national level, only a very small increase in sex ratio was found in children below 6 years category, with sex ratio improving from 914 to 919 female per 1,000 male. Now what this implies essentially is, as a society, there has been high levels of son preference, which essentially meant people have used illegal instruments such as female feticide to create which resulted in a skewed sex ratio in our population. The present survey shows that the skewed sex ratio in our population continues as people continue to uphold son preference and finding various illegal means of retaining this practice. Total fertility rate in the national level has declined from 2.7 to 2.2 children per woman, meeting some of the cherished goals of population control policy of the country. Percentage of children 12 to 23 months who are fully vaccinated also increased from 44% to 62%. The major health surveys undertaken in India have focused on maternal and child health since the beginning, because these are the two indicators in which the health data in the context of our country fall short of international standards. Among the rationale for this focus was the high share of diseases of children under 15 years and maternal disorders in the total disease burden of India. In recent times, the share of non-communicable diseases is increasing, contributing a larger share of diseases and cause of mortality. Non-communicable diseases include cardiovascular diseases, cancer, diabetes, for example. Some observers argue that the current health surveys are not collecting adequate information about NCD in the context of India. And this happens because of our excessive focus on maternal and child health in all the health surveys. The high cost of healthcare has been a cause of concern for observers for a very long time. It has been pushing, according to some scholars, millions of people below the poverty line. According to some observers, between 1986-87 and 2004, the absolute expenditure per outpatient visit in rural and urban areas increased, affecting the ability of the poorest to access healthcare. The costs have increased in both public and private sector facilities. However, the increase has been more than 100% in private facilities. Therefore, in the scenario where more and more people are accessing healthcare in the private sector because of the inadequacies of the public sector, they are increasingly having to meet their needs through high expenditures that comes out of their incomes or savings or loans, etc. Expenditure for drugs, which represent about 70 to 80% of out-of-pocket expenditures for outpatient, have been increasing with time at a rate that is twice as fast as the general price increase. What this essentially means is that while price of all commodities are rising at a certain period of time, the cost of drugs have been rising twice as fast. Essentially, obtaining cheaper and affordable standard medicines for people is increasingly becoming difficult with the rising cost of medicines. Government expenditure in health, including external funding, loans, aids, etc., accounted for 22% and private expenditure for 78% of the total expenditure in health in 2004-05. This is essentially worrying because it shows that unlike many other countries of the world where healthcare is publicly provided, we in our country, much of the expenditure in health is actually privately funded and private expenditure essentially. In some categories of targeted health campaign, donor financing was available in the past, but over a period of time, these programs, including family planning, malaria, immunization and other diseases, the share of donor funding has been reducing and declining. This hasn't kept up with increasing matching funds from the government. In the reference year, when this particular study was conducted, only 10% of the public funds, 2% of total government expenditure came from external donors. Public expenditure in health in India is much lower compared to neighboring countries such as Sri Lanka, China and Thailand. The graph that you see now actually shows the comparative levels of expenditure in healthcare, and it also shows public versus private spending in health in neighboring countries of India like Bangladesh, Sri Lanka, China and Thailand. And if you look at it, India's total spendings in healthcare is a little bit above Bangladesh, and within this, public spending is a smaller percentage and private spending is a much higher share in the context of India. If you compare this with what is happening in Sri Lanka, China and Thailand, where overall spendings in health is high, and also there is much better balance between public and private spendings in healthcare. One of the goals of healthcare policy is to create greater involvement of to increase public investment in healthcare, to make healthcare not so expensive for people who really need it. There's a growing emphasis on universal healthcare globally. Universal healthcare is defined as all persons receiving health services they need, including health initiatives designed to promote better health, such as anti-tobacco policy, prevent illnesses through vaccination, and to provide treatment, rehabilitation, and palliative care of sufficient quality to be effective, while ensuring that these services does not expose user to financial hardship. A joint report by WHO and the World Bank in 2015 highlighted the necessity for universal healthcare for people to ensure that all persons all over the world have access to affordable healthcare services. The universal healthcare thus defined has two components: health services coverage and financial coverage. Health services coverage essentially means that no matter where one lives and no matter which socioeconomic group you belong to, you always are able to access health services in your vicinity. Financial coverage means that you have the ability to pay for the health service that you require. Universal healthcare is often shown through this diagram of this cuboid diagram, in which this shows the extent of population. One dimension of it shows extent of population who is covered by present healthcare services. It shows services, it also shows which are the services that are being covered by the kind of financing that is available. It also shows in one axis the direct cost that is proportionate to the costs of covered. It also shows how to reduce and it also shows the dotted arrows actually show the extent to which these current provisionings need to be expanded to include other types of services, to reduce cost and share the cost with other forms of financing, and also how health services can be expanded to include larger shares of the population. While everybody agrees that healthcare services should be available for everyone and that everyone should be able to afford it, there is less agreement on who should be providing the services. There is increasing emphasis on the regulatory as opposed to the provisioning role of the state in health policy debates, which means that the role of the state is to regulate the service providers but not necessarily to provide the service itself. State action, it is believed, should supplement rather than substitute market solutions through a number of regulatory mechanisms such as accreditation of hospitals, digitizing of patient records, putting in place safety standards, and so on. Market failures occur, according to some commentators, due to information asymmetry, and it was the role of the state to provide checks against this phenomenon. We have recently obtained the National Health Policy 2017. In fact, it has been formulated as we speak, and it's very new. Some of the key issues that has been addressed in the NHP 2017 includes reduction of maternal and infant mortality rates, increasing life expectancy, reducing fertility rate, creating universal health coverage, providing affordable access to drugs, diagnostics facilities for all, The NHP also proposes to increase expenditure in public health as a proportion of GDP from the current 1% to 2.5%. A greater emphasis is put on combating non-communicable diseases, and public-private partnership is viewed as the key strategy to deliver efficient and affordable healthcare to all. If you look at the health data that we have seen so far, the NHP 2017 does all the right things and says all the right things for the right reasons. It is talking about the age-old issues of maternal and child health care in which improvement is required. It is also talking about combating non-communicable diseases, which commentators point out as being required. It is talking about increasing expenditure in healthcare, which is also the need of the hour. Some observers have identified these as the positive aspects of the National Health Policy 2017. To summarize, the NHP 2017 moves from the provisioning of selective care at primary level to more comprehensive care with linkages to referral hospital, which essentially means that the government would make efforts to not just deliver primary health care to poor people in remote locations, but also attempt to link up primary health care facilities with secondary and tertiary services. It does away with user fees and cost recovery at public hospitals to deliver free drugs, diagnostic and emergency services, which is a huge improvement and would be a huge relief on the burden of expenditure that poorer people face when they have to spend a large amount of money for healthcare cost. NHP also aims to improve the staffing of public health facilities in remote areas and develop a cadre of public health managers. This is absolutely essential because the lack of staff and trained people at public health facilities in different parts of the country also leads to abysmal healthcare outcomes for people. The NHP also plans to strengthen public healthcare facilities such as public hospitals at the district and sub-district level and converting some of these into teaching centers. This is an improvement from a situation where the best quality medical colleges and hospitals were located only in state capitals or national capitals, whereas elsewhere in the country suffered from a tremendous dearth of trained and committed medical and healthcare personnel. Some criticisms of the NHP. Among the criticisms of the National Health Policy is the suggested greater role of the private sector that is envisaged by the policy. The policy specifically mentions public-private partnership and sees the state as performing a more regulatory rather than a provisioning role. Budgetary allocation for health in India is at present 1.3% of the national GDP, while the NHP envisages to increase this proportion to 2.5%. The date by which it requires to meet this target is very far away, it's 2025. And one wonders whether the healthcare requirements of the population would not have increased many folds by then, and would such a proportionate increase would actually help the kind of support and investment in public health care that is required at the moment. So the worrying thing is, if the NHP 2017 is planning to make all these positive shifts in providing healthcare and making it affordable, providing better coverage, improving health indicators and so on and so forth, how is it going to be able to do this without increasing the investment in healthcare simultaneously? Another reason why the National Health Policy 2017 is considered to have gone back on a promise that it had made many years ago is that it is failing to make health a justiciable right. Therefore, while the draft health policy formulated in 2015 recommended making health as a basic right, the NHP 2017 is silent about whether healthcare could become a basic right for all citizens of India. And that remains one of the key shortcomings of the National Health Policy 2017. With this, we come to an end of the brief discussion and an introduction to the health policy in the context of India. This is by no means a comprehensive coverage of the health policy, which is a vast area and a very complex area. Among the things that we have not covered comprehensively, but we hope to cover in some of the other modules, is the national health missions, whereby government is creating initiatives to improve healthcare access, and especially tracking and monitoring maternal and child health in many parts of the country. To summarize what we have learned in this module, we began with the discussion about why healthcare should be a social policy concern. We looked at the situation of vulnerable groups in the society who may suffer from a large extent of health deficit, but whose ability to access healthcare remains poor, primarily due to the high cost of healthcare, lack of access to healthcare, and also due to information asymmetries, because of which they may not know what kind of health care they should be seeking. We tried to look at the transitions in health policies and the different focus that health policies have had in India over a period of time. We've tried to understand how costs could be reduced. We have also looked at the notion of health insurance and the extent of the population that is covered by health insurance at this point in time. We have tried to understand why health data is systematically collected by any country, and how health data such as what has been collected by the National Family Health Survey in its various rounds becomes a basis for both assessing and evaluating the way in which older healthcare policies and interventions has been working, and also used as a guideline to frame future policies. We have looked at the concept, we have just introduced the concept of universal healthcare, which is the key policy development in the context of health in globally today. And we have also seen how the understandings from universal healthcare is being reflected in the National Health Policy 2017. We've looked at the positive transitions in National Health Policy 2017, as well as some of the shortcomings. One of the shortcomings is not making healthcare a justiciable right. With this, we come to an end of this module. You are encouraged to consult all the readings and references that are provided at the end of this module. Especially there's a series in the Lancet which had a debate over universal healthcare and about healthcare policies in India in 2011. The link to that series is being provided to you. You're also encouraged to look at the consultations around the National Health Policy, the draft National Health Policy 2015, leading up to the formulation of the National Health Policy 2017. With this, we end this module. Thank you for listening to us.